students, welcome to my YouTube channel Medicoeducation. Today we are going to learn about COPD, that is chronic obstructive pulmonary disease. This is a respiratory disorder. We have learnt about many respiratory disorders before this. So chronic obstructive pulmonary disease is a combination of diseases. We are going to learn about the following objectives, that is definition, key factors, causes, etiology, risk factors, clinical manifestations, pathophysiology, complications, diagnostic evaluation, prevention, medical management, surgical management, nursing management, and health education. COPD is a disease state characterized by airflow limitation that is not fully reversible. COPD may include diseases that cause airflow obstruction, example emphysema, chronic bronchitis, or a combination of these diseases. So as I already mentioned, COPD is a combination of diseases, that is emphysema and chronic bronchitis. COPD includes chronic bronchitis and emphysema. Asthma is not considered part of COPD due to its reversibility. As we already discussed that this is irreversible, as asthma is reversible, so we do not include it in COPD. Chronic bronchitis. Let's discuss what is chronic bronchitis. Chronic bronchitis is a chronic inflammation of the lower respiratory tract characterized by excessive mucus secretion, cough, and dyspnea associated with recurrent infection of the lower respiratory tract. Emphysema. Emphysema is a complex lung disorder characterized by damage to the gas exchange surfaces of the lung, that is alveoli. Key facts according to WHO. Chronic obstructive pulmonary disease (COPD) is the third leading cause of death worldwide, causing 3.23 million deaths in 2019. Nearly 90% of COPD deaths in those under 70 years of age occur in low and middle income countries, that is LMIC. COPD is the seventh leading cause of poor health worldwide, measured by disability-adjusted life years. Tobacco smoking accounts for over 70% of COPD cases in high-income countries. In LMIC, that is, low and middle-income countries, tobacco smoking accounts for 30 to 40% of COPD cases, and household air pollution is a major risk factor. Causes: tobacco exposure from active smoke or passive exposure to secondhand smoke, occupational exposure to dust, fumes, or chemicals, indoor air pollution, biomass fuel, that is wood, animal dung, crop residue, or coal is frequently used for cooking and heating in low and middle income countries with high levels of smoke exposure. Early life events such as poor growth in utero, prematurity, and frequent or severe respiratory infections in childhood that prevent maximum lung growth. Asthma in childhood and a rare genetic condition called alpha-1 antitrypsin deficiency, which can cause COPD at a young age. Risk factors: exposure to tobacco smoke, people with asthma, occupational exposure to dust and chemicals, and genetics. Exposure to tobacco smoke. The most significant risk factor of COPD is long-term cigarette smoking. The more years you smoke and the more packs you smoke, the greater your risk. Pipe smoke, cigar smokers, and marijuana smokers also may be at risk, as well as people exposed to large amounts of secondhand smoke. People with asthma. Asthma, a chronic inflammatory airway disease, may be a risk factor for developing COPD. The combination of asthma and smoking increases the risk of COPD even more. Occupational exposure to dust and chemicals. Long-term exposure to chemical fumes, vapors, and dust in the workplace can irritate and inflame the lungs. Exposure to fumes from burning fuel. In the developing world, people exposed to fumes from burning fuel for cooking and heating in poorly ventilated homes are at higher risk of developing COPD. Genetics. The uncommon genetic disorder alpha 1 antitrypsin deficiency is the cause of some cases of COPD. Other genetic factors likely make certain smokers more susceptible to the disease. Primary symptoms: cough, sputum production, dyspnea on exertion. Dyspnea may be severe and often interferes with the patient's activities. Weight loss is common because dyspnea interferes with eating. Now let's discuss what is the pathophysiology of COPD. Abnormal inflammation response of the lungs due to toxic gases. Response occurs in the airway, parenchyma and pulmonary vasculature. Narrowing of the airway takes place and there is destruction of the parenchyma that leads to emphysema. Complications: respiratory infections. People with COPD are more likely to catch colds, the flu, and pneumonia. Any respiratory infection can make it much more difficult to breathe and could cause further damage to the lung tissue. Heart problems. For reasons that aren't fully understood, COPD can increase your risk of heart disease, including heart attack. Lung cancer. People with COPD have a higher risk of developing lung cancer. High blood pressure in lung arteries. COPD may cause high blood pressure in the arteries that bring blood to your lungs, that is pulmonary hypertension. In other words, you call it pulmonary hypertension. Depression. Difficulty breathing can keep you from doing activities that you enjoy, and dealing with serious illness can contribute to the development of depression. Diagnostic evaluation. How are we going to diagnose COPD? Health history, pulmonary function studies, spirometry, ABGs, that is arterial blood gases, chest X-ray, CT scan, screening of alpha 1 antitrypsin deficiency, blood tests, medical history, physical exam, spirometry, pulse oximetry, and CT scan. Prevention. How can we prevent COPD? Smoking cessation. This is the single most cost-effective intervention to reduce the risk of developing COPD and to stop its progression. Healthcare workers or healthcare providers should promote cessation by explaining the risk of smoking and personalizing the at-risk message to the patient. You should tell the patient and encourage them: if you are a smoker, you are at risk of developing COPD. Medical management. Medical management here includes pharmacological therapy. You are going to give the bronchodilators, and bronchodilators relieve bronchospasm by altering the smooth muscle tone, and they reduce the airway obstruction by allowing increased oxygen distribution throughout the lungs and improving alveolar ventilation. You can see there is a normal airway, then in an asthmatic attack, muscle spasm is occurring. After that, you have given the bronchodilator, and after medicine, the muscles are relaxed now. This is how bronchodilators work. You will also be giving corticosteroids. A short trial course of oral corticosteroids may be prescribed for patients to determine whether pulmonary function improves and symptoms decrease. Other medications. Other pharmacological treatments that may be used in COPD include alpha 1 antitrypsin augmentation therapy, antibiotic agents, mucolytic agents, antitussive agents, vasodilators, and narcotics. These are some of the medications other than bronchodilators and corticosteroids you are going to use for COPD. Lifestyle changes. How lifestyle changes can help you in COPD management. Lifestyle changes can help improve symptoms of COPD. Quit, quit smoking or vaping. This is the most important thing to do. Even if you have been smoking for many years, quitting can still help. Avoid secondhand smoke or smoke from the indoor cooking fires. Stay physically active. Protect yourself from lung infections. Get a flu vaccine every year. Get a pneumonia vaccine. Get all available COVID-19 vaccines and make sure you have had the latest boosters. People living with COPD must be given information about their condition, treatment, and self care to help them to stay as active and healthy as possible. Lung therapies. How lung therapies will help you with COPD? Oxygen therapy. Oxygen therapy is one of the lung therapies you are going to teach your patient. If there isn't enough oxygen in your blood, you may need supplemental oxygen. There are several devices that deliver oxygen to the lungs, including lightweight, portable units that you can take with you to run errands and get around town. Some people with COPD use oxygen only during activities or while sleeping. Others use oxygen all the time. Oxygen therapy can improve quality of life and is the only COPD therapy proved to extend life. Talk to your doctor about your needs and options. Oxygen therapy basically depends upon your needs, so you should talk to your doctor before you start your oxygen therapy. Pulmonary Rehabilitation Program. These programs generally combine education, exercise training, nutrition advice, and counseling. You'll work with a variety of specialists who can tailor your rehabilitation program to meet your needs. Pulmonary rehabilitation after episodes of worsening COPD may reduce admission to the hospital, increase your ability to participate in everyday activities, program. Surgical management. How are we going to manage COPD surgically if medical management fails and there is no cure with oxygen therapy? Surgery is reserved for severe COPD or when other treatments have failed, which is more likely when you have a form of severe emphysema. One type of surgery is called bulectomy. During this procedure, surgeons remove abnormal air spaces, that is bulla, from the lungs. Another is lung volume reduction surgery, which removes damaged upper lung tissue. Lung volume reduction surgery can be effective at improving breathing, but few patients undergo this major, somewhat risky procedure. Lung transplantation. Lung transplantation is an option in some cases. Lung transplantation can effectively cure COPD but has its many risks. Control of breathing. Here you can practice with me how you can control your breathing. So, here we start. Hold your breath. Inhale, hold, exhale. Practice. Inhale, hold, exhale. I hope you are practicing. Very good. Let's move. Everyday activities can make you feel short of breath. For example, getting dressed, walking to the bathroom, doing jobs around the house. When you learn to control your breathing, your stamina will improve. You will then be able to do more before feeling short of breath. Feeling short of breath may make you feel panicked and anxious. This can make your shortness of breath worse. When you feel short of breath, try to stop speaking and moving. Give yourself time to recover your breath. Relax or distract yourself by focusing on a picture or a view from the window. Nursing management. Maintain airway patency. Assist with measures to facilitate gas exchange. Enhance nutritional intake. Prevent complications. Slow progression of condition. Provide information about disease process, prognosis, and treatment regimen. Perform a history and physical exam to assess the client's respiratory status, respiratory management. Provide instructions on how to use supplemental oxygen at home, oxygen therapy. Avoid using oxygen masks on client with COPD if they are not having difficulty in breathing. Administering aspirin, brufen, or other non-steroidal anti-inflammatory drugs that are called NSAIDs. You should avoid NSAIDs. You should avoid using oxygen masks on clients with COPD who are not having any kind of breathing difficulty. Administer oxygen if needed. Fluid management. Monitor oxygen saturation levels, breathing patterns, pulse rate, chest sounds, respiratory rate and depth, lung function. Encourage the use of supplemental oxygen. Avoid using alcohol and tobacco. Proper use of supplemental oxygen equipment. Goals and outcomes. Maintain a normal respiratory rate and depth. Take medications as prescribed. Maintain a normal oxygen saturation level. Get enough sleep. Ability to maintain activities of daily living. Maintain normal pulmonary function as measured by spirometry. Let's practice control of breathing once again. Hold, exhale, hold, inhale, hold, exhale, hold, inhale, hold, exhale, hold, inhale. I hope this is helpful for you. Thanks for watching.